So I'm transitioning to have more of a system look and just to kind of frame this a little bit in terms of British Columbia. And after I speak and just try to frame our discussion, we're going to have opportunity to just go around the room, because we are aware that many of you are involved in exactly the same issues as we are. You're doing many things, and often we don't know about what we're doing and how those things fit together. And so the goal of today is to set the stage for a possible collaboration or an alliance, to explore what that might look like and how we might frame that, and hopefully as an outcome be able to do something in British Columbia that makes sense for us. So the British Columbia Centre for Palliative Care was established in 2013 under an Institute for Health System Transformation and Sustainability, funded by the ministry. And essentially, the goal is to ensure excellence in compassionate, person-centered care for everyone affected by serious illness. So you see in the framing of what we're doing that we are a center of excellence. Excellence is part of it, but compassion is the other part of it. And we really want to make sure that that happens for people living with. And so again, that focus that we've heard about so clearly this morning. In Canada, as we know, our population is aging, and sometimes we're not living well longer. Sometimes we're living sick longer with multiple chronic conditions, and we're having that health-related suffering that Dr. Rajgopal talked about. Most people spend most of their time at home. There's a high dependence on family caregivers, and sometimes the supports are not there that they need to provide that care well. However, with the implementation of medical aid in dying, we have begun a societal conversation about end-of-life care, and that has resulted in calls for more compassion, more action, a real option around palliative care for everyone who needs it. And we know that historically, the Economist publishes a quality of death index about every 5 years, and Canada has been progressively falling behind. We used to be one of the countries that led. The term palliative care was coined in Montreal, in Canada, by Balfour Mount in the 80s, and yet now other countries are eclipsing us and moving further ahead. And we were 9th in 2010, and we were 11th in 2015, behind the US. If that doesn't motivate you, I don't know what else, what else can. And very much this is a public health issue because everyone dies. This is an issue that affects all of us at some time in terms of our own mortality, but also in terms of the people that we care for. How many in this room have not experienced a death of a friend or a family member in the last 5 years? Probably no one. So this is something that touches every one of us, and yet we find it difficult to talk about, and sometimes in that lack of conversation, suffering is not addressed. And the kinds of issues may not be poverty, or they may be. We have people who struggle for all sorts of things. Quality of life isn't something that, unless it's a specific focus, and unless we ask about goals of care, may not be something that is addressed with people. And the suffering, as we've heard, is often preventable. But we need to have an intention and a focus and awareness of that. And over time, we need the resources to address it, so that whether you live in Vancouver or whether you live in a small town somewhere or First Nations community, that access is the same wherever you are and whoever you are. Quality of care, we have not been measuring this care. There are some good things on the horizon, which I'll talk about later, but right now that's kind of the context, and certainly equity challenges. And I'm not going to say too much about this slide because we've heard a lot about that and seen the pictures of physical suffering, the dependence on others, that's part of serious illness, the suffering that comes from isolation, from loneliness, from not being able to talk about your concerns and feeling like somehow you're a shame or an embarrassment to others or a burden. And then again, this idea that decision-making, often in the absence of conversations, decisions are made that may not be consistent with your goals or values, and so we're wanting to change that. We know that 90% of us on average have a time where if you asked us, we would say, don't pursue aggressive measures. When I'm at that point, 90% of us have that threshold. But if we're not asking us, in a study that I was involved with, Only 32% of the time in the health system are we identifying that threshold and are we acting on it. So we're missing care for the 2/3 who we're not having conversations with. We know about these end-of-life trajectories. I'm a physician who works at the Cancer Agency, so the cancer trajectory on top is one that I'm very familiar with. People are kind of going along, and then there's this more active phase of deterioration in the last 6 weeks of life or so. That's changing as well. It's becoming more of a chronic illness. And so there's kind of a marker that says, now you're palliative, and now we can implement certain things. But that's less and less true as we're better and better at managing things. And so many people live on that middle trajectory, which is the one of chronic illness. But there's still often this hope that with one admission or the next treatment, they're going to recover and be well again, whereas that's not usually the case. Every incident, every sentinel event, there's deterioration, and they never quite get back until one day it says there will not be a distinct terminal phase. The week we die, will start out like any other, and some unpredictable calamity will occur. Amongst those of us with advanced heart failure, we will have had a 50-50 chance to live for 6 months on the day before we died. So if we're waiting for that signal that says, now you're palliative, we will miss it for over half the patients because we don't know when that day will be, but we can talk about hoping for the best and planning for the worst and having the advanced care planning conversations that identify the thresholds that are important. And in dementia, again, that's kind of turned on its head because if we want to have the conversations, we have to have them really early while people are still able to participate fully and really communicate their values to us. And we know that the loss and bereavement issues continue throughout the trajectory as people are losing function and status and less able to do things, and roles are shifting, identities are shifting, and people are needing additional supports. And pain and other symptoms may only happen very close to the end or may not happen at all. So when we're talking about palliative care for our populations, and when we're talking about compassionate, person-centered care, we need to keep in mind that that looks very different for every person, no matter whether you fit this trajectory or another trajectory. This is care that all of us need to be involved with. And quality care, these are really old studies, and I've looked at newer studies, and sometimes they have fancier terminology, but essentially most people want these things, and that hasn't changed. Quality, pain and symptoms to be managed. We heard a lot about pain as a major contractor, and when I talk to patients, I say, if you're using your energy to fight pain, you don't have energy for the things that are most important to you. A sense of control, needing to feel like I'm still the person that I was and I can still make decisions that are right for me. A clear approach to decision and roles as things shift over the course of an illness. That relationships can grow and be strengthened in this time. For my mother, who felt like she was a burden, to be able to say, Mom, you've cared for others your whole life. Let us give back to you. Let us do for you what you've done for so many, and that this is not a burden, but a joy. That we are still who we are before, during, and after an illness. We don't change. We may have less capacity, but we are who we are. And that meaning and completion, the tasks of the dying role and the tasks of living well until the last moment that you live are still there, and there is opportunity to create meaning and purpose and to be valued by the people that you care for. And obviously this extends into bereavement as that family learns to live without the person who may have been so central, and as they go through these transitions over and over again and the multiple losses. So what is the context in British Columbia? We have over 800,000 seniors, somewhere on that continuum from healthy living into coping with end of life. In 2012-13, we had about 31,000 deaths. Now in 2015-16, that's 35,000 deaths. It's an annual increase of about 11 to 14%, depending on the year. So it used to stay quite steady, but we're now in that time when this is increasing. In the studies that we did where we analyzed everyone who died, 58% were designated as palliative, but often that was in the last weeks of life. It wasn't early enough to make a real difference. 55% had access to home care, 20 to 30% had some access to specialized palliative care. Home deaths sat at 18%. In the US, as I've mentioned, 29% of people died at home because they have a much more robust hospice service that comes in very actively and aggressively and ensures the supports are in place. Hospice, 15%, and acute care, 41%. When I started at Fraser Health in 2001, deaths at that time were 63% in acute care. So, and you often hear that figure in other places, so we have made a significant difference. And some of you in the room at Porterfield and others have been part of that, and 25% in residential care. 2% of our population is coping with end of life at any one time, but that population uses 35% of the expenditures in the healthcare budget. So the opportunities, not just at a personal level, but at a macro level, are huge. 21% of that is for frail in residential care, 9% for frail in community, and 5% for palliative care. Because initially when palliative care people heard 35%, they said, where's the money going? We're not seeing it. And just to give you some stats around medical assistance in dying, 1 to 4.5% of total deaths at this time. So 99%, 96% plus of our population is not accessing hastened death. They are needing the kind of supports we are talking about now. One of the issues is that the greatest expenditures are often associated with the least value. So we spend a lot of money and we don't improve the quality of life. We provide care that is potentially non-beneficial and often unwanted. And so that's part of the opportunity for improvement. And when James Downer did a survey looking at how is it possible that a third of the care is not beneficial, he found that often it was due to this lack of conversations. People had not had the conversations. They're in a crisis. They say, do everything, because that seems like the right thing to say, rather than to say, we had this conversation. Dad was really clear. He didn't want machines. He wanted to die at home with his family, and to make that a part of the plan, rather than just kind of getting onto the treadmill. So we need to shift our thinking. We need to shift from this idea that palliative is a stage that we can recognize and anticipate to thinking about a palliative approach, an approach to care that says you matter because you are you, and you matter till the last moment of your life, and we will do all we can to support you to live well. What does that look like in residential care, in acute care, in home care? 80% of deaths are from chronic life-limiting conditions. Are we ready as a society, as a culture, to embrace that, to make sure that the care people need is available for them? We are lucky. iPanel is this group of nurses who've been doing this research, and we need to blend the principles, the concepts of palliative care with BC's been a leader in identifying chronic disease strategies, and we need to blend these. Often, even if you look at some of the, there were end-of-life pathways built and guidelines and so on, they ended kind of just managing the disease until the end, and there was no transitioning to what is this person wanting, what are the end-of-life issues, and so we need to blend those things and bring them together. So we need to have care that helps people live as well as they can for as long as they can. And we have this slogan that helps us to just get that message across in 3 simple words: earlier, more, better. Earlier conversations, more of the right things that support people, and better. As we start to do this, and as we start to measure it, then we can say, okay, we're here now, and here's where we want to be, and what's the road to improvement look like for this? So compassionate, supportive care for all diagnoses, all providers, in all settings that complements disease management. And one of the key things in a key study that showed that palliative care was as effective as a novel chemotherapy drug for people with lung cancer, in that it provided them 3 months longer survival. And when they analyzed what did the palliative care people do that was different than usual cancer care, what they found was they gave people a roadmap. They put them back in charge, and they said, here's where we are going, here's the 2 or 3 ways we could get there, what are your options, and how do I support you in this journey? And it meets the triple aim, which is we improve value for patients, we improve value for the health system, and we improve the quality of life and care. And there's tons and tons of evidence. More and more and more and more and more studies. Like these are the 7 or 8 initial studies, and now there's probably 100 studies that have proven this evidence-based intervention makes a difference. And so how do we move from being a death-denying, grief-illiterate society where we have the elephant in the room, but we're afraid to acknowledge, and we don't know how to bridge, and we don't know how to discuss. We need a societal shift in paradigms. Promoting healthy living. As long as you're well and you're living well, we want to support you to do that. But ensuring access to palliative care supports for people who need them when they need them. To empower patient family voice and stories. I think as we hear the stories, it's the stories that stay with us. We'll remember the stories Dr. Raj told this morning. They'll stay with us and maybe they'll inspire us. To promote understanding of loss and grief, to normalize the dying role and tasks of dying, and to accept that this is part of living and we can help people to live well and to die well in a compassionate community. So an ethics of caring, we've heard a lot about today, versus medicalized dying. And we know that when we do this, when a small group of people moved by compassion move towards others with practical ways to relieve pain and address suffering, we know that that benefits not only the receiver but the giver of the service. And as we do that, we all grow and our organizations grow, and we know we're making a difference, and it enhances and builds sustainable change in our community. Thank you very much.